Hello, I'm going to show you how to do a MIM contour of the prostate prior to a MIM ultrasound MR fused biopsy. The patient that I'm going to show you is interesting. He's had an ablation and there is probably some recurrence at the edge of the ablation site in an area that it might be very difficult to identify without a fused MR image to help guide the biopsy. He, like all our patients, has had a multiparametric study at 3 Tesla. We've done diffusion-weighted, dynamically enhanced and T2-weighted scans. MIM has a nice workflow here where you can look at the prostate, you can review the dynamically enhanced scans with a little movie, and you can also look at the high B-value diffusion scan, and you can also look at the ADC. And the first thing that we're going to do is we're going to contour the prostate. You can see that this prostate is an odd size and shape, and that's due to the previous ablation, and that's one of the ways that doing this contouring is so useful, because we can contour directly to the shape of the prostate. So it's now going to ask me to contour the lesion. One of the nice things about MIM is we can contour these lesions on the scan that shows the lesion best. So I'm actually going to choose this one, and I'm going to start contouring my lesion. And you can see that when I contour on this one, it's actually giving me the same volume on all of the others. And if I want to, I can just go onto one of the other scans and contour on that one. So this session is now complete. I've contoured the prostate, I've contoured the lesion, the seminal vesicles and the urethra. We now go on to the next workflow, which is to create the biopsy plan. Now, one of the key things about MIM, which is different to any of the other software, is that it allows me to create a virtual transrectal probe. One of the problems with biopsying the prostate transperineal and getting a good match with the MRI is the MRI is obtained in a different axial plane. What MIM allows you to do is it allows you to reslice the prostate, giving you the plane of the ultrasound. And you do that by using this virtual transrectal probe. We place the probe so that the line of the posterior capsule is parallel to the transrectal probe, and that's when you're in theatre, you try and align the transrectal probe to the posterior capsule of the prostate. What MIM does is it then reslices the MR to give you a picture of those resliced scans, which is this one, and you've got the grid, which will also be there, the template grid, at the time of the biopsy. Now I'm going to move the grid so that the big D row lies on the urethra and that the row 1 lies just on that posterior capsule. That is going to be the biopsy plan. So once that's saved, we can then send that data up to the MIM cloud and it can then be accessed for use. We will also get the data back from theatre, and the exact coordinates that the biopsies were taken can be then fused onto these images, and then the pathologist who reports on these samples can similarly give us a report showing exactly what each of those samples contained.
So this is a challenging case. This is a man who had radiotherapy some time ago which recurred, and he had focal salvage cryotherapy to the right-hand side of the prostate, and I think he's got a recurrence just to the medial aspect of that, so between the right lobe and the midline anteriorly. I've biopsied him once, and those biopsies came back negative. That was a cognitive biopsy. Since then, the lesion got stronger on MRI characteristics, and the PSA has gone up to 2 point something. And I've suggested to him that it's time to rebiopsy this. So we're going to use an image-guided system. We're going to use the MIMSoft software to see if that can improve our accuracy of getting to this difficult part of the gland, which is just to the right of the midline anteriorly. So what we're going to do is superimpose the MRI information, which is being captured by contouring the prostate, contouring the tumor, contouring the seminal vesicles as visual fiducial markers, and contouring the urethra. So we've got a skeleton of the prostate that we're going to superimpose in real time on the ultrasound images to help me get the needles into that position. So the next phase is the probe insertion. You'll see that the probe is surrounded by a water bath, and this allows us to capture the images from the prostate without distorting the prostate itself. So I want to get the urethra on big D, which I have now. You can see that the rectum hasn't been compressed, so the prostate is not being compressed by the probe. We're sitting a little bit away from the prostate so that it has the same contour as it had when it was captured with the MRI. Everything you see in grayscale is from the real-time ultrasound that you've just seen. Everything that has a line or a color is information from the MRI. In white is the contour of the prostate itself, which you can see approximates the ultrasound very closely. In red is the contour of the tumor as drawn by 3mm planimetry by Dr. Claire Allen. And we can see in yellow the proximal aspects of the seminal vesicle as they attach to the back of the prostate. So we now have the images that I've captured in real time. So we're just going to check that everything is nicely aligned. And then I will be presented with a target that I then have to fill so that I can maximize the chance of making a diagnosis if this is prostate cancer, and also depicting the full heterogeneity of the tumor by getting samples from the full extent of the lesion. So we're now going to do the biopsies. For that I need a grid. To place that. My task now is to fill the red lesion with needle tracks. So I'm just coming to the right of the midline. We can see the needle coming in there. This is the middle, and I could feel resistance in the deployment. This is hard tissue. Oh yes, we got a good bit of tissue, yeah. Okay, so we're coming in to capture the lower component of the tumor. That's good, that's excellent. So I'm going to try just to capture that bit of the tumor that we haven't yet captured. Okay, this would be impossible to do without registration. That's great. Okay, we're done. So we just want to check now on the axial that the target is full in terms of its sampling, and I think it is. Okay, I'm very happy with that. So this patient will spend about 10-15 minutes in recovery. He should have no discomfort afterwards because of the local anesthetic, and he'll go home 2 or 3 hours from now.